So nephrotic syndrome in pediatric population is very frequent. That's why I made this video. Let's start with a case of a 4-year-old patient that admitted to our emergency department complaining about swelling in both legs, swollen eyes, and distended abdomen. When we asked the parents, they told us that the urine output was decreased as well. So you can see obviously that the peritibial edema is shown here. You press on the medial side of the tibia and you see the pitting edema here. So in this case, in the severe edema cases, you suspect nephrologic diseases, cardiologic diseases, or even liver diseases. But in pediatric population, we mostly see nephrotic syndrome due to nephrologic diseases. So that's why we approach this patient according to the most commonly seen cases. So what is nephrotic syndrome? It's the heavy proteinuria, hypoalbuminemia, edema, and hyperlipidemia. Most children have it due to minimal change disease, and 80% of them respond positively to steroids. What are the criteria of nephrotic syndrome? It's the nephrotic range proteinuria. It's not just simple proteinuria. You just calculate the urine protein over the creatinine ratio and you see it's above 2 milligram per milligram. You have also hypoalbuminemia, which means that the serum albumin is below 2.5 gram per deciliter. You see the edema that we just saw in the previous slide, and hyperlipidemia that is above 200 milligram per deciliter. So if we talk about the causes according to the age, the mostly seen age range is from 1 to 10 years, which is caused by minimal change disease. But in older children, you must suspect focal segmental glomerulosclerosis, and the ones that are under 1 year old, you should suspect some genetic nephrologic diseases. The typical presentation, patients come to you complaining of edema and decreased urine output. Sometimes they have peritonitis because in the glomerular diseases, the immunoglobulins can leak as well from the glomerulus, and the patient have a bit of immunosuppression stuff. That's why they are mostly prone to have peritonitis. So what are the red flags that promote biopsy or urgent workup? As we mentioned before, it's mostly seen from the 1 to 10 years. So if the patients are younger than 1 year old or even older than 10 years old, you should suspect other diseases and make a kidney biopsy. If you have hematuria, if you have impaired renal function, because in this disease you don't have elevated urine or creatinine levels, so if you have them, you should suspect other diseases. If you have low complement levels, well, decreased C3 is very important here because may have some other diseases like lupus and so on. And if it's steroid resistance, when do we call steroid resistance? If you start the prednisolone or corticosteroids to this patient for 8 weeks and you see no resolution or no remission in these cases. So how to diagnose it? You order for urine dipstick to check for the heavy proteinuria, and then you calculate the protein creatinine ratio. You check for albumin, creatinine, lipids, and electrolytes in the plasma, and then you consider cultures if the patient has any fever or abdominal pain that may make you think of peritonitis, and if they're coughing or have any respiratory symptoms, because the fluid overload or the fluid building up in the lungs may cause respiratory distress as well. The kidney biopsy is indicated in the cases we have mentioned before. So when to hospitalize these patients? If they have severe edema that may cause respiratory compromise, if they have acute kidney injury, if they have severe infection like peritonitis, if there is thromboembolism, or if their oral intake is decreased. So you see this patient, you diagnose them with nephrotic syndrome. What to do next? You can start corticosteroids immediately for 2 milligram per kilogram per day, daily for 4 to 6 weeks, and then decrease it to 1.5 milligram per kilogram per dose on alternate days for 4 weeks. If these patients show remission, then it's steroid-sensitive nephrotic syndrome. If they show relapse within 2 weeks of stopping the steroids, then it's steroid-dependent nephrotic syndrome. But if you see no remission, even though you gave them the steroid for 8 weeks straight on daily basis, then this case is steroid-resistant nephrotic syndrome. So what other medications you may give to these patients? Diuretics, if they have severe edema as well. Our first-line treatment is furosemide. You can give them 1 milligram per kilogram per day. Or even if you have very, very severe refractory edema, then you can give them albumin infusion and follow it with loop diuretics like furosemide. If you have heavy proteinuria or the patient has hypertension, then you can give them angiotensin-converting enzyme inhibitors as well. But while giving it to them, you have to monitor for potassium and creatinine because it may cause any increasing in these both parameters in the plasma. But if you have resistant to steroid nephrotic syndrome, you can consider other treatments like cyclophosphamide, calcium urine inhibitors like cyclosporin or tacrolimus, or even rituximab. And talking about the immunology of this patient that may be impaired because of the leakage of immunoglobulins from the glomerulus, you should consider pneumococcal conjugate vaccine and booster with polysaccharide vaccine per age. And you should tell them to have their annual influenza vaccine. The live vaccines should be administered before starting steroids, and if the patients have any infections, you should, like peritonitis or sepsis, you should give them antibiotics as well. Finally, if we're talking about the supportive care and lifestyle of these patients, we have to remind them to restrict the salt intake because it may cause edema and hypertension as well. We should tell them to avoid high protein diets because it can cause impairment in the kidney function as well. Treating the hyperlipidemia by modification of their lifestyles, and because we gave them already steroids, then we have to monitor their